OK, so I'll just give it a start. Je vais commencer. Le français va suivre dans quelques secondes. C'est un honneur pour moi. It's an honor for me to welcome Dr. Rakesh Jetly to be speaking on Unlocking the Mind, the Role of Psychedelic Medicine in Modern Mental Health. This lecture is in the context of the MPA course, MPA 583. Dr. Jetly will be talking about all the policies surrounding the psychedelic medicine. And the presentation will be presented in English, but the questions can be in both languages. Dr. Jetly is an internationally recognized expert in military and veteran mental health, suicide prevention, PTSD. He's the former chief psychiatry of the Canadian Armed Forces. He continues an impressive research career and is now the co-investigator in multiple studies that focus on innovative treatments for mental health disorders, including psychedelic-assisted psychotherapy. Among other many other roles, he serves as the Chief Medical Officer of Medicine Innovation Group, is an advisor with the United Nations, focusing on the development of a mental health strategy for uniformed peacekeepers, and is a mental health advisor of SIMVER. Donc, c'est la maîtrise en administration publique qui reçoit aujourd'hui Dr. Jetly pour une conférence qui se nomme Libérer l'esprit, c'est sur les psychédéliques et la santé mentale. La conférence va être présentée en anglais. Les questions peuvent être dans les deux langues. Colonel Jetly est un expert de renommée internationale sur la santé mentale des militaires, des anciens combattants, en prévention du suicide et en troubles du syndrome post-traumatique. C'est l'ancien chef en psychiatrie des Forces armées canadiennes. Il poursuit une impressionnante carrière de chercheur. Il est aussi co-chercheur dans plusieurs études qui sont axées sur des traitements innovants pour les troubles de santé mentale, y compris la psychothérapie assistée, évidemment, par psychédéliques. Il est entre autres médecin en chef de Medicine Innovation Group. Il est conseiller auprès des Nations Unies, où il se concentre sur l'élaboration d'une stratégie de santé mentale pour les casques bleus, et il est conseiller en santé mentale pour l'Institut canadien sur la santé des militaires et des vétérans. Alors, je vais juste confirmer que l'assistance nous entend. Ceux qui sont en ligne, can you write to me on the chat if you hear? And yes, great. Thank you. Thank you. Thank you. Merci beaucoup. OK. Voilà.
Thanks very much. Technology is fantastic.
Always.
We need to have some kind of pandemic or something that gets us good at working with this kind of technology. It's fantastic to be here. You know, I've always had a soft spot for RMC, and it's been years since I used to come here and, you know, give talks from time to time. We're gonna, because of the nature of the course, we're gonna talk about a few different types of. Oops, the slides aren't advancing. How do I advance the slides? Are they?
No, but if you just the arrow there doesn't work.
No, it doesn't. That's this one here.
This one here. Oh, you got it.
Okay, yeah, I got it. Okay. Okay, so just a quick disclosure. I am sort of the chief medical officer of a company that's developing some of the psychedelics, and not much is going on in the field right now. We can talk about that afterwards. And there's going to be no mention of any products or anything that the company is working on. You know, what I'd like to do, given the nature of the talk, I'm used to usually giving more high scientific sort of clinical kind of talks, but it's going to be more of a, you know, brief review of the legal and political situation in Canada with respect to some of these medications. We'll talk a little bit about treatment of mental illness and examples of current treatment that's going on and sort of the potential promise of psychedelics. This is interesting just in terms of, just as I reflected upon this, you know, years ago, I mean, previous government, conservative government, so there were some of the MDMA renaissance was going on. And so, you know, the media interviewed me and asked me about sort of my thoughts about MDMA and some of the promise of the therapy. And I gave a comment, the most caveated comment one could give. I basically said, you know, if research is done, if evidence-based treatment shows that these drugs are safe and effective, then it gets published in peer-reviewed journals, and organizations like the ISTSS bless it and put it in the treatment guidelines, then we may consider it. That was kind of the comment that I gave. It went into the media. people started to sort of, share it. They wanted to share this quote. Things got out. So I was playing golf with a friend, sort of that same sort of Friday night, and I got a call from the Surgeon General, my boss. And some of you are young, but there was a thing called the BlackBerry before there were iPhones. So my BlackBerry goes off, after I finish playing golf, and it's the Surgeon General. He calls me and says, "What did you say? What did you say in the interview? They're all going crazy in Ottawa." I said, "Well, I told him exactly what I said, carefully with caveats and all this stuff." He goes, "Oh, geez, okay, I have to call the reporter back and tell them, no matter what, we're not going to give it to members of the military." And I sort of said, "Okay, so you as the Surgeon General are going to say that if there is a safe and effective treatment that's going to treat PTSD, no matter what, we're not going to give it to our soldiers." He goes, "Oh, good point." So we ended up not doing that. And so it was kind of interesting following the next couple of months, because there were a series of sort of things in Ottawa back and forth between public affairs and government sort of saying like, why did he say that? Well, that's his area of expertise. He should be saying things like this. So it was all becoming sort of back and forth. And really, so it's really interesting now, sort of a decade later, to be here at RMC talking about the same topic. So I think it tells us a little bit about where the field is going, but it also tells us a little bit about the controversy. So one of the things that we tend to be a little bit fussy about, and we see it somehow, there's sort of sloppy language in the sense of people talk about psychedelic medicine, they talk about it all sort of as a group. And what they tend to do is they tend to lump all the medication together. They tend to lump MDMA with psilocybin, with all the different kind of medications. But I think it's important just to look at their different medications. They have different side effects, different positive effects. And so lumping them together. And just like we sometimes use the term antidepressant to describe a medication, but then we end up using the antidepressant for anxiety and different things. So nomenclature gets a bit sloppy in medicine. So MDMA itself, which is sort of the champion in PTSD, isn't actually a psychedelic. And it's more of an empathogen, an actogen, sort of experience of openness. So that'll be part of the theme as we sort of talk about it. Psilocybin, on the other hand, like LSD, is a true psychedelic that causes sort of the actual psychedelic experience, which is distorted sights and sounds. You can lose your sense of time and space. People take them and also feel intense emotions. It can be quite horrifying at times. There's something called ego death. So in terms of thinking about these medications that are all kind of lumped together, ketamine, which is very popular right now for recreational use, but also for depression, things like that. We're starting a study in Toronto where we're looking at ketamine as potentially a treatment for concussion and depression at the same time. And that's more of a dissociation, sort of out-of-body experience, but not a true psychedelic experience. So just from a strictly sort of phenomenological process, all of these medications are slightly different, which means the therapeutic approach is different. What happens, how you sort of guide somebody through the experience is quite different as well. Just another way of looking at this, sort of classic psychedelics, and enactogen, dissociative anesthetics, they're all sort of different types of medications. Sorry, the slide is altered a bit on this computer. So history of psychedelics, they were natural substances initially that cause unusually strong experiences, color, sound, smell, taste, and touch. So all of the senses can be affected intensely, been around for thousands of years. They're often in the roots, in the ground, in different plants, and they can have these experiences. There can be psychological effects such as deep understanding and hallucination. And this is kind of where they've been incorporated in cultural practices, throughout the world in terms of having sort of this changing experience and insight. They're plant-derived initially, and when we look back, and you can look at caves from years and years ago, at least 4,000 or 5,000 years ago, different cultures use these medicines as part of their things. There's different classes. We've talked about this already. So the dissociative ones, the classic psychedelics, and this. So the substances are illegal, and they're under the Controlled Drugs and Substances Act in Canada. So which means the possession, sale, and production are generally illegal, except for, so I created some of these slides to present to our international colleagues as we were comparing sort of policies in different countries. So again, but in Canada, there is medical and therapeutic use. So Health Canada has granted some exemptions for the use of these medications in certain medical and therapeutic settings. I'll talk about the Special Access Program in a minute. There have been decriminalization efforts in certain cities like Vancouver and Toronto in the past, sort of comes and goes, but it kind of is caught up in the whole opiate thing. Again, the governments don't fully understand what they're talking about. So the opiate crisis, we decriminalized small amounts. Some people did it with psilocybin, but it's used quite a different way. And then for research and clinical trials, there's ongoing research into the potential benefits of psychedelics for treating conditions like depression, anxiety, PTSD, substance use, and there has been some promise. So really in terms of recreational use, it's illegal, which does complicate doing research in it, but there are sort of different kind of attempts that are going on. This is often what you'll see in some of the psilocybin shops. So one of the big companies shut down all of their stores, but I know in Ottawa, in Toronto, I think in Kingston as well, there were shops where people could do it. One of the shops got tired of being, they were raided again and again and again. So now they've gone sort of completely online. So it is possible to get these mushrooms and different countries. I mean, in the Netherlands, you can get mushrooms, but you can't get the drugs. There's different kind of substances. So the Section 56 exemption, sorry, the slide, can we make that smaller, Stephanie? The thing is blocking the, I don't know if there's a way of, or is that part of the sharing, or minimize it, or is it, if it's not possible, then we can.
Here we go.
Okay. And so there's a thing called the Section 56 exemption. So all of these controlled substances. So I'll give you an example. If you have a prescription for Tylenol 3s and you're flying somewhere overseas, it's actually against the law to take opiates out of the country, right? So you automatically, the Minister of Health in Ottawa gives you a Section 56 exemption to sort of transport and move some of these medications as long as they're right. So the Section 56 exemption, which some countries don't have, so at least we do have that. So it's granted by the Minister of Health federally, in the interest of medical, scientific, or the public interest. So which means then you can legally possess, produce, or distribute controlled substances. So a lab has to have a Section 56 exemption if they're going to make these drugs or study these drugs. So and if we're doing research, we have to ask for it as well. So you have to go to Health Canada and ask for this exception. And so that allows the research to occur. And sometimes in the past, the therapeutic use, if people were going to have therapeutic use and things, we have to get a Section 56 exemption. So the Special Access Program, again, it's cut off for some reason at the top, but this is the Special Access Program, which the government has in place, which allows for certain medications that aren't licensed in Canada to be able to give them to people. So the classic example would be a cancer treatment. Let's say you've tried everything possible for a certain type of cancer. There's a drug that you want to use, but it's not licensed in Canada yet, but it may be in Brazil or it may be in Germany. You're allowed to ask Health Canada, I have this patient that has this specific cancer, I've tried this treatment, and I want to get this medicine in from another country, right? So that's Special Access Program. And a couple of years ago, because of the interest in the psychedelics, looking at treatment-resistant depression, end-of-life anxiety for psilocybin, and MDMA for PTSD, the government was quite progressive and actually allowed special access to be used for these medications, which, again, other countries don't have. And so basically you can write to Health Canada and you give the initials of your patient. They have depression. They tried this drug, this drug, this drug. Psychotherapy didn't work. And I'd like to give them this medication from this supplier. And within a week or so, you get approval. It's about a 70% approval right now. So it's not quite as easy as your usual medication, but given the fact that these aren't sort of licensed medications yet, I think it is a step in the right direction. You can get a class exemption as well. Like if you have a clinic that's treating a lot of people with a certain illness, you could say, over the next year, I want to treat 10 people, and that they make sure that you're getting it from a legitimate supplier that makes the medications and things like that. So it is limited in the sense that it's for clinical treatment only. It's not for research. You can't use special access if you want to do research. You have to go back to that Section 56 exception. Within academia, there's an interest, right? I mean, I think it's kind of interesting where you've got the recreational use, you've got the legal use, you've got companies trying to make money, but within the academic centers, there's still quite a bit of interest. And at the University of Ottawa, they have a psychedelics and consciousness studies program in the university. And it's a really interesting program if you want to look at it online, where it's interdisciplinary education, including sort of looking at societies and the history of the use of the psychedelics, different cultures, how they're using it. There's going to be research on consciousness, mental health. There's training as well in training people how to become therapists, because one of the things that is a concern if these medications ever do become sort of legalized, we'll talk a little bit about the treatment in a bit, there's going to be a sudden shortage of trained therapists to be able to do this. And so this is a program that's right in Ottawa. There's a chair of psychedelic research in Calgary, and this is sort of Leah Mayo, who's a colleague, and she was in Ottawa visiting just a few weeks ago, looking at sort of, she's done a lot of work in the cannabis space and things like that. So they're looking at different kind of the substances, psilocybin, MDMA, and ketamine, sort of in general, lumping them together, as we kind of said. And they're doing things right now. They're looking at concussions, addictions, and different kind of treatments as well. Queen's University right here is also, has a Center for Psychedelic Health Research. Money came from sort of Dimensions Health. Dimensions has donated $1 million to get this going. And they're, again, looking at different kind of research proposals, looking at alcohol use disorder and psilocybin right now, but also interested in PTSD, MDMA. So there's interest in a lot of the academic centers. And part of what's happening in this renaissance of psychedelic research is you've got King's College, Imperial College, you've got Johns Hopkins, you've got Stanford, you've got Langone University in New York as well. So very legitimate sort of academic centers are doing this research, which is taking it away from sort of the farmhouses in Vermont kind of idea. And then just as an example, sort of ketamine, which is an old sort of anesthetic, a dissociative anesthetic, is being used sort of as a treatment for depression, treatment-resistant depression. There is some sort of psychotherapy involved as well. So in the Canadian Forces, the military will pay for it, Veterans Affairs will pay for it. So ketamine at least has sort of crossed that divide of sort of, into sort of legitimacy now. So the ongoing issues, there was a Senate committee, on Veterans Affairs that was looking at sort of psilocybin, and I actually testified in front of this committee. And so one of the questions that they asked was, why aren't we getting this into more veterans? Why aren't we getting them this treatment? And I had to point out that it's still illegal. Like, so they changed, okay, so what can we do? And so they've come out encouraging more research and funding. And so I think that's going to be the key in terms of getting this. So they really urged sort of a call to action because of, the lack of response to the traditional treatments. On the other hand, Veterans Affairs is paying, more for medical cannabis than sort of all the other drugs combined that are going for veterans in Canada. So it's a bit of a controversial area because the evidence for cannabis isn't quite as strong as we'd want. So I think there's more research needed in that area as well. So I'm going to switch a little bit, talk about this. You can see this picture. There's a Canadian soldier, and that's the Netherlands. You can see poppies, all the cliches that you can imagine. So just as a reminder, Canada was involved in the liberation of the Netherlands. So Polish troops and Canadian troops. The Germans occupied the Netherlands from 1939. Their royal family actually came and stayed in Ottawa, sort of escaped the war. They went into exile. Their Princess Marguerite was actually born in an Ottawa hospital, which temporarily they made not Canada, so that she could still remain Dutch. And so there's a lot of interesting things. And so in terms of that connection, and historically there was a Dutch psychiatrist from Leiden University who treated traumatized Holocaust survivors, and he used LSD. So this is 60s and 70s, a guy named Jan Bastians, and it's a bit hard to read this, but this is from an Israeli newspaper. And so basically, a survivor of the Holocaust in the concentration camps traveled from Israel back to the Netherlands to receive this treatment because they weren't responding. Bastians was a bit of a controversial guy, and he treated PTSD. The actual diagnosis didn't exist until 1980, although we knew that people were suffering. So this was sort of before the current understanding of PTSD. And he was a huge man. There's some great videos and things of him treating people that have been suffering since the Holocaust, the things that they saw, unmentionable things. And he used sort of small amounts of LSD just to sort of break down some of the barriers, get some of the knowledge out of them. So it was controversial at times, and the government didn't exactly like what he was doing. And he's a hero in some places, a villain in others, and academia kind of turned on him later in his career. But now, as sort of this sort of psychedelic renaissance, as we're talking about, is coming, it's very interesting in terms of the work that is done. So it's not just the North American thing. We've talked already a little bit about what the psychedelics are. We're going to talk a little bit about psilocybin, MDMA, medicine-assisted psychotherapy. And so just very quickly, MDMA, remember we said it's not a classic psychedelic. It's more of a stimulant, right? It's more like a stimulant drug. And because of that, the way it acts, it actually creates this release of certain chemicals that makes somebody sort of euphoric, stimulated, but also to some extent, it breaks down some of the barriers to social anxiety and things like that. And so it's a synthetic drug. It's made, unlike psilocybin, that comes from mushrooms, and initially made in 1912, in German company Merck. And they were, 1927, they were looking at, as they were advancing, they ran out of money, so they stopped. Sort of came back in 53, and people were looking at it and testing it in humans. Then in the 60s, they published the protocol for MDMA synthesis. And so the idea of this as being a drug, as a chemical, as a treatment, was sort of thought about. And then in the 60s and 70s, things were advancing slowly. But then in the 70s, they talk about, there were two things that sort of happened, and they always say that it was the war on drugs, and Richard Nixon and the US president sort of doing that shut down a lot of this research. The initial sort of war on drugs that sort of Reagan went further in, but it was also because there was much, much more caution about medications. There was a drug called thalidomide that caused a lot of, that was being used for morning sickness for women, and it led to these thalidomide babies, kids that were born with sort of, limbs missing and things like that. So on one hand, there was a lot of concern about medication being rushed into use without proper research. And on the other hand, there was a real concern about drugs that are being used recreationally, and MDMA and psilocybins and these drugs were. So that kind of led to this different. There's a little bit about, people like Shulgin, who became aware of MDMA and started to use a lot of these. The problem with this is that a lot of people tend to use the drugs themselves, a lot of these scientists, and that sort of made them fall into ill favor. So he tried it as well. In the 70s, they started to use MDMA in the San Francisco, sort of west coast of the US, to sort of help patients through it, even though by now it started to become illegal. So it was basically an underground sort of psychotherapy, has kind of existed for a long time, starting on the west coast of the US and certain pockets of Europe, but really became overtaken by the illicit use and ecstasy and things like that in nightclubs and raves and things. The harms of MDMA, because it's a stimulant, it can cause sort of, increased heart rate, which is tachycardia, arrhythmias. If you're prone to have heart problems, it can cause problems with the heart problems. It can cause increased temperature. There's a thing called serotonin syndrome, which is like many of the medications that people take, the SSRIs, the antidepressants. So if an overdose of that can cause too much of this chemical serotonin, which can cause stiffness of the body and overheating. Sometimes you'll see that. There can be a short-term negative mood effect, 24 to 48 hours. And so following the non-clinical use, we've sort of looked at that. And then when you look at it, the problem with it, looking at how it's being used recreationally, it's not in a sort of a safe environment. The dosage is controlled. There's often alcohol and other drugs mixed as well. So need to sort of look at the differences in terms of what's happening. And you can see it's unclear because of the polydrug use in the patterns. So the Renaissance, which is sort of what we're in right now, and I'll talk about this sort of briefly. So in 1986, MAPS, which is the Multidisciplinary Association for Psychedelic Studies, sort of came. Lots of money. San Francisco, they started off as a charity, as a foundation, and basically set out on a long journey to legalize and get these listed, get the FDA indication for this drug for PTSD. The amount of money spent was unbelievable, research sort of all over the world. And really, this was a mission of a guy named Rick Doblin. He's quite an interesting character. They started to work with Stanford, Johns Hopkins, all the different universities, and really worked on establishing it. And so just to fast forward it, this August was when the FDA made its decision, and they decided not to approve it. So they're back to the drawing board, but we'll talk a little bit about that in a while. But so this is part of the renaissance of people just trying to advance these medications. How does MDMA work? I mean, it works in a way like the other antidepressants with the serotonin, releases some of these neurotransmitters. I'll go into sort of a less sort of a scientific sort of look at this way. So it basically increases serotonin, which is the medication. So it has a positive effect on mood and creative thinking. So it changes the way you're thinking, the state that you're in while you're taking the medication. The effect of that is, decreases depression, anxiety, fear, aggression, and increases self-confidence. This is sort of while you're under the experience of it. Dopamine and noradrenaline, again, just like any other stimulant, increases the level of alertness, arousal, consciousness. So you're taking it sort of more around you. And it increases calmness and relaxation. It releases oxytocin. Oxytocin is, the same chemical that gets released when women breastfeed, for example, and things like that. So it creates that connectedness and empathy and understanding with people. We talked a little bit about the physiological effects, the increased heart rate, blood pressure, temperature, sleep disturbances. And that's part of what makes research with this quite difficult, because people can have these weird sensations, heart, and the question is, do you call those adverse effects in a study, or is that the expected effect? And this is where the scientists are struggling, because if people are having not so great experiences, that's part of the drug that they're taking. And these are usually sort of short-lived. So euphoria, sense of well-being, increased sociability and empathy, and sort of reduced anxiety. And so you could see the excitement that scientists would think about, because people are thinking, hey, this would be a great drug for schizophrenia, people that are not connected, or people even with autism spectrum, because they sometimes lack the empathy and the connectedness with people. So the drug has a lot of promise in terms of the kind of things that people are looking at. In the brain, in PTSD, thinking about it, there's a part of the brain that sort of runs amok, which is called the amygdala, the fear center, which is sort of like the alarm system in the brain. So it reduces the amygdala, which means it reduces the hypervigilance, the fear that people have all the time. So what a great thing. I mean, while you're doing psychotherapy, to be a bit relaxed. Oxytocin and prolactin, again, increases trust and therapeutic alliance. So the idea is, if you're taking this medication while you're doing psychotherapy, a better trusting relationship with your therapist, which again, it can also make you vulnerable to a boundary violation with your therapist if you start to sort of become too much of that. And then because MDMA, unlike the classical psychedelics, you're not really having a psychotic or a psychedelic experience where you're seeing things. You're actually still in a real state. So you can actually do work while people are on the medication. We'll talk about the psychotherapy in a minute. So to talk a little bit, so one of the things that we're trying to emphasize, that I want to try to emphasize here, is in a nutshell. This is going to be a lecture on psychedelic assisted psychotherapy, but I was just in Taiwan. I presented some of the stuff in Turkey, and people are quite concerned. We're not talking about replacing Prozac or Paxil with MDMA to take it every single day for the rest of your life, the way people are taking these medications. We're talking about 1, maybe 2 doses, maybe 3 doses sort of ever, right? That's what we're talking about in clinical settings. You're not going to the pharmacist and picking it up. They're in the safe at the hospital kind of idea. And nobody is proposing taking this medication outside of a clinical concept without psychotherapy, right? So I'm going to talk a little bit in the next few slides that, there's preparation before you take it. Then there's the actual experience when you're dosed with the medication, and then there's therapy afterwards. The whole thing can take about 6 months. So it's about a 6-month treatment protocol, and it's not sort of, it's not that. So the preparatory session, there's usually 2 therapists. You meet with the person a few times ahead of time, talk about their trauma, understand what's happening. You educate them a little bit about MDMA, what the drug is, what they may or may not feel while they're on it. And so you set up all kinds of rules in the therapy. If you do this, we'll do this, and this kind of idea. With psilocybin and other medications, you even talk about the therapeutic touch. Like if you get too excited and you start to leave, I might touch you on your left. You get consent and agreement for all of this stuff. The therapy sessions are taped. They're videotaped for the whole time for learning later on, and also just sort of protect everybody, because the person will be sort of intoxicated. You talk a little bit about, what the therapy is going to consist of, because, you might go off on tangents. We might bring you back to the trauma. The idea is to work on your trauma. That's rarely necessary because people know why they're there. So all of these kinds of things are there. You talk a little bit about the transient mind states that people might go through while they're intoxicated, and there might be some anxiety, there may be something. And so we'll sort of help you, sort of support you through that, through the active sort of the drug experience itself. So multiple sessions. You might show them the room where the therapy is going to take place. It's sort of a special room that has comfy chairs. There'll be music playing. They might have shades to cover their eyes, depending on what they're going through. So all of this stuff is done in preparation. There's a really important thing. Again, this is why kind of like it doesn't help if you have PTSD to go take some MDMA and go sit in the woods kind of idea. You know, one of the things we talk about with modern medicine, modern psychotherapy is the set and setting, right? So your mindset needs to be there in terms of like, what am I doing? I'm here for therapy to talk about my trauma, to go into some dark places. You know, and the setting is where it's done in a comfortable room with music and all of this. And there's really a lot of interesting things where you look at this research where, you know, if you're doing a trial, all the rooms are standardized all over the world with the same, literally with the same artwork, same things. You know, you have to be prepared for somebody that might feel nauseous while they're on it. The bathroom has to be close by because the experience lasts several hours, right? It's several hours that the therapy session is going on. And here you can see, so the two therapists with somebody in the comfortable area. So the therapeutic relationship is set up. You know who's going to sort of take you through it. The therapists are trained. I've sat through the training myself. It's quite long and arduous for the MDMA treatment, but so it's a sort of a standardized approach that takes place. So the session 6 to 8 hours. It's two therapists. You can just imagine the cost as well. This is one of the criticisms is it's a very, very expensive. It could be $30,000-$40,000 that people are going to end up paying for this. You know, once it gets out of the clinical realm. Then so with the therapy itself, for people that are sort of trained in sort of this cognitive therapy where it's very structured, very, you know, look at the thought, look at the feeling, look at the behavior. This is very open-ended. This is old school kind of therapy where wherever the person goes, they go, and it's unguided. So it's kind of a self-discovery type of therapy. And then afterwards, there's integrative psychotherapy. So after the medicine, after the treatment, you meet them afterwards for an hour, hour and a half, 2 hours, depending on the type of work that you're doing. Because of the brain changes, because the changes in how you see yourself in the context of your trauma, you may come up with new insights afterwards. So the idea of later on of being able to chat with your therapist and saying, hey, you know, I went out and I went to this place, and all of a sudden I noticed that I never saw this before, but now I'm noticing this about my house or my husband or spouse or whatever, that type of thing. So there's really helping them to sort of make sense, to sort of make that commitment back to normal life. You know, so why was PTSD chosen, or why are we excited about PTSD? I mean, one of the things that, you know, I think sort of, you know, as people in uniform, when we first started our trauma clinics, and I was lucky enough to sort of help build the one in Halifax, we had lots of money. We had lots of money. It was post Romeo Dallaire, sort of like, hey, nothing's too good for our troops. It was before Afghanistan, but it was after the former Yugoslavia, Rwanda, Somalia, things like that. We had a plane crash in Nova Scotia that we're looking after some folks when a plane crashed in Peggy's Cove. So we got all the best treatment. We got everything, followed all the treatment guidelines, and thought that that was it. So we've got the best treatment possible, the evidence-based treatments. And then probably by around 2004, 2005, 3 or 4 years later, you know, people would come to me and say, well, we've done everything for this person, they're still sick, right? And so the best evidence-based care, especially in military and veteran populations, maybe 30-40% of people are going to have a really good response. Maybe, you know, 50% of people are going to have a partial response, but about half the people aren't going to respond and are going to remain ill. And so we're looking at sort of from that moment on, we've been looking at the treatments that we have just aren't good enough, right? And why? Is it a moral injury? Is it guilt and shame? Is it all of these types of things? The other thing is that the current therapies that we have are extremely difficult. They're extremely hard to sit there every single week and talk about when your best buddy blew up in front of you or you were raped or something like that. So people, you know, throw up the night before, they get muscle aches, they really can't do it. And the dropout rates can be as high as 50, 60, 70% in some of these exposure-based therapies where you're asked sort of, it's uncomfortable for the therapist too, just going into details. So one, even if people go through the treatment, the response is really not as good as we'd like. And then there's dropout rate. And the other thing is that as we start to think about, you know, PTSD, we start to think about the mistake we often make in sort of separating the brain from the rest of the body. I mean, these are body diseases. Mental illness is a body disease. And we've known since World War I that soldiers and exposure to combat has led to premature death. We keep forgetting about it and we attribute it to smoking and drinking and drugging and all that stuff. But when you look at it, there really is a lot more going on in somebody's body. They have higher pain, arthritis, diabetes, heart disease, all of these conditions that often have inflammation in common. So we need to start looking at treatments that can settle the inflammation in the body, not just sort of treat the brain abnormality. So PTSD is the ideal sort of condition to look at in this sense. So the MAPS, we talked about the MDMA trial. They had like amazing results. I mean, the MDMA for PTSD just crushed it. That's from the New York Times, phase 3 trial, the largest study. So they did multiple, what I call phase 1, phase 2, and phase 3 trials. They basically had, 67% of the people no longer qualified for a PTSD diagnosis, which is unheard of, which is like 3 times what you normally expect, and 88% had clinically meaningful reduction. So really, those of us that are close to it fully expected the FDA to approve this as a drug. It was going to start to become available for people, and it was almost a done deal. MAPS sort of spun off into a company called Lykos, which is a for-profit pharmaceutical company. We're expecting to raise $1 billion to sort of get this thing across the world. In June, there was a meeting and an advisory board sort of advised the FDA not to approve it. And good friend of mine is on that advisory board. And it was kind of interesting because he asked all the tough questions, but then he was the only one that voted yes. So it was kind of ironic, a friend from UCLA. And really, we all expected it. And they were rejected for a couple of reasons. One is the non-blinding. So it's really, really hard to create a placebo for a psychedelic, MDMA, or things like that. You can't sort of give somebody something and they can pretend they're on something else. So part of the traditional randomized control trials is that the patient and the therapist should be blind as to what treatment you're having, right? And so some of us in the industry are saying we may need to think about what the gold standard study is, because as these medicines come along, I mean, you're not going to be able to do the blinding. Safety, some concerns. We talked about the heart and things like that. They didn't feel that they captured that as well. And there were a couple of boundary violations where therapists sort of, were touched patients that did inappropriate things. And again, I'm not sure that's the FDA's job. That's more of our sort of licensing positions and things. So it really was quite a shock. And then the company is going to have to either redo the phase 3 trials or change things around. But it's a setback, but not a complete crush. And what people are thinking about in Europe is try to get more naturalistic studies going. It's interesting at this time to think about, the three groups that are in this industry, and I know the industry a little bit. There's the evangelicals that believe these drugs are beautiful, they're natural, this is the whole world should be taking these drugs. And they kind of feel that the science and the Health Canada and FDA are just sort of a pain in the ass, and they're kind of getting in the way. And unfortunately, Rick Doblin, who's the founder, and I know him quite well, is in that group. I mean, he'll stand up on stage and say, we're going to eliminate all violence in the world by 2050 and things. He's a very sweet man, but he's a bit naive. And interesting to say at a military college, we'll all be out of work, I guess. But I wouldn't give up my day job. And so the evangelicals are there, and that can get difficult because it affects research, right? Like if, research needs to be skeptical. Like I did research looking at, an endocannabinoid, a synthetic cannabis for nightmares, and it turned out to have a positive result in like 2013, 2014. And, I honestly said, hey, if it doesn't work, it doesn't work. I'll publish that it didn't work, because you have to have some skepticism. Now, in this case in particular, when you've got medications or drugs that people are on it, then your patient gets randomized to the MDMA, you're excited, the patient's excited. So they're saying that's going to bias the outcome. You're going to do better therapy for people that are on medication versus not the medication. So that's the evangelical, the risk of that. So Paula Schnur, who's one of the senior people in the National Center for PTSD, always says, I want skeptical, skeptical, non-believing scientists to do some of the research, because then I'll trust the findings. So there's evangelicals, then there's venture capitalists, the people that just want to make a lot of money, and they got in it for sort of the wrong reasons to make the money, and thinking it was cannabis 2.0. So again, not the right people to be in it, because drug development and drug research takes about 20 years, not a year. So wait a minute, where's my return on investment? That's not the way to think about medical research. Then the third group are clinician scientists. I kind of like to put myself in that group, where we're actually just trying to figure out other ways to help our patients. And if this is promising, let's do it. So I think the three groups, it's important to keep your mind on that. And if you're looking in the online, you'll sort of pretty easily be able to identify the three groups. So briefly about psilocybin, it's sort of very similar. So the difference, of course, is it's a mushroom. You know, it works in a similar sort of a serotonergic kind of a receptor, the same kind of receptors where the antidepressants, SSRIs, and those kind of things work. It's in about 100 natural mushrooms all over the place. It grows in Canada and places like that, you know, all over Europe. It can also be synthesized chemically and biochemical. So it's an interesting thing. There's a split in the industry. You know, do we get mushrooms and then extract it from the mushrooms and give it to people because it's natural? Or do we sort of make it synthetically? And I've kind of had both ways. I prefer the latter only because it fits the medical model more. Like if you want to have people accept it, what happens with Health Canada is if you're getting it from the mushrooms, then it's not really a drug. It more falls into the cannabis area and the natural food almost kind of idea. So it gets quite complicated, and then the FDA will actually go inspect where the mushrooms are grown and all of this. So it gets a little bit messier. So I'm kind of the camp where synthetic is fine. And at the end of the day, molecules are molecules. So the psychedelic in the West, you know, it really is only until about the 50s that people really start to think about sort of the effects of psilocybin, even though in indigenous communities it was there for many years. And so the first documentation was sort of in the 50s, you know, by Gord Wasson. Then Hoffman, who's the creator of LSD, he became interested in Sandoz. Again, these are the large drug companies. So he extracted, purified, and identified the psychoactive substances of psilocybin, and, you know, took a little bit himself and kind of liked the idea of it. So that's about the 50s and 60s again. So the excitement, but again, shut down sort of in the 70s, right? So 50s, 60s, we can sort of see the excitement. So Timothy Leary was interested. So this is a little bit different where Harvard was involved, but unlike now where it's being done at Johns Hopkins and all of these legitimate universities, a lot of it was done sort of more sort of in smaller communities, in farmhouses, in places, barns and places like that. And then 71, you know, along with the other products, the UN Convention on Psychotropic Substances was signed. A lot of the US kind of pushed this. I think only two countries, I think Jamaica and I can't remember the other country, didn't sign it. So the whole world was kind of bullied into signing it. So this sort of went away. Again, the Renaissance occurred in the 90s with the Hefner. Again, raised money, philanthropy, people believing in, you know, this is kind of where it is. In 1996, the FDA started with Charles Grob, who's, you know, I think he just passed away last year, started looking at sort of the phase 1, which are the simplest clinical trials. And since then, a lot of work has been going on with, you know, this Imperial College in London. They've done brain imaging studies where they've shown sort of the changes in the brain last about a month in terms of your actual sort of your sense of self, your cognition area, really, really important referential areas of the brain. So that's why we kind of think that, you know, one dose of psilocybin and then psychotherapy sort of following after that is going to be, you open up that window for therapeutic change that wouldn't happen otherwise. So that's kind of where things are coming. So treatment-resistant depression, obsessive compulsive disorder, nicotine dependence. I was involved in some of those studies with Johns Hopkins where they're showing one dose of psilocybin and behavioral therapy helps people up to 60 to 70% quit smoking. The best treatments that we have for smoking cessation works about 20% of the time. So really kind of almost hard to believe kind of studies if you didn't look at the paper itself. Alcohol dependence, cocaine use, a lot of different kinds of things. And one of the most interesting earlier studies that kind of hit like CNN and 60 Minutes was the end of life anxiety indication for psilocybin, which is fascinating if you look at it, where older people that have cancer and they're going to die, they just become overwhelmed with fear of death, anxiety. So one dose of psilocybin and some psychotherapy, and it sort of brings them peace before they pass. So that's one of the areas with special access where we can get it for people just to sort of, die in that way. Two large organizations involved in depression study, USONA, which is a not-for-profit, and Compass Pathways, which is definitely for-profit, are sort of working hard towards looking at sort of getting these indications. And really, again, we can't take it for granted given the FDA's latest decision, but the idea would be within a year or two they'll be ready with their phase 3 trials. Now, psilocybin, it's interesting. This is from Professor David Nutt, a British guy. He was an advisor for the British government, and got fired because he made public statements sort of on the rules within Britain. And he famously once said, more people in Britain die from falling off of horses than taking these medications, right? So just this whole idea, like, he's really trying to sort of change the thinking about, we think about how evil these drugs are. It's kind of, it might be hard to read there, but in terms of the safety of these medications, harm to others and harm to users. And there's a scale. And at the far end is alcohol, then heroin, crack cocaine, methamphetamine, regular cocaine, tobacco, all of these different substances. And mushrooms are at the very end in terms of all the bad things you're going to do. He sort of advocated that if you're going to have a vice, this is probably a better vice than alcohol or heroin or cocaine or those types of things. So there really isn't an established toxicity in terms of what an overdose is, but it's really important to understand that if you are prone to mental illness, depression, psychosis, mania, and this is again through the non-clinical use, it can exacerbate existing mental illness. So in terms of they're not counting that as a safety thing, but I think we need to think about that. And what ends up happening is these initial trials, you remove people at risk of some of those things if they have a family history of psychosis or schizophrenia, those types of things. So the studies, so once we release these sort of into sort of regular clinical care, we may see an emergence of sort of more negative outcomes. Just briefly, psilocybin is taken when you eat it. Your liver makes it into a drug called psilocin, and psilocin is the actual active drug that sort of helps, and it's very similar to serotonin. And I won't go into the details of that. It's a classic psychedelic, so I think it's really important to contrast it now with MDMA. We talked about when you take MDMA, you're still sort of aware of where you are. It's really unusual to have that extreme sort of experience. So that's why when you're taking the MDMA, you're actually doing psychotherapy during those 6 to 8 hours. You're talking about your trauma, you're talking about your insights, your therapists are helping you to sort of integrate some of those things. On the other hand, these kind of medications like LSD and DMT and psilocybin, you're actually having a full psychedelic experience. So you're seeing things, you're not really there, the time gets distorted. And there's a really interesting thing called, sort of the ego death. Like you actually could lose the sense of who you are completely for transit, which can be quite frightening. But if you've had childhood trauma and trauma your whole life, and that's interwoven with the sense of self, then maybe that ego death is what needs to happen to sort of rebuild, right? So that's the idea. So it actually can be it can be okay for some people, it can be amusing for some people. On the other end of the spectrum, it can be absolutely terrifying. And so the therapists that are with them with the psychedelic experience of a psilocybin aren't doing psychotherapy, they're supporting the person through the experience. Sometimes they can be very boring, sometimes they're exciting, but at the end of the day, you're reassuring them, hang in there, hang in there. And the idea of psilocybin-assisted psychotherapy is more to take advantage of the brain changes afterwards with the psychotherapy. So again, quite different in terms of what's actually happening. So, increased heart rate, pupil dilation, gastrointestinal motility. That's a fancy way of saying that, nausea, vomiting, diarrhea. So sometimes people throw up during it. One of the things that's really important is, people will go to the bathroom quite often. So you've got to have a bathroom close by, but you cover the mirror because who knows what they're going to see, right? So you cover the mirror, you do all of these different kinds of things. You have people bring in their own food. So that's, again, don't try to bring them food from the kitchen because who knows what's going to happen. So they need to think about what they're going to bring if they're going to eat and things like that. So how it may work, I mean, one of the things about it is that at the core of mental illness, you have a rigid view of yourself, right? Like, I'm a bad person, the world is unsafe, the world is dangerous. And what a medicine like a psychedelic can do is it might allow you to relax that rigidity of how you see the world, right? I think that's really the important thing. You know, maybe I'm not such a bad person. Maybe the world isn't quite as dangerous. Not that it isn't, but it gives you the opening, right? And I think the smoking cessation is a very interesting one because, you know, Matt Johnson and his team from Johns Hopkins just uses good old-fashioned, you know, cognitive behavioral therapy they use for smoking cessation in everybody else. You know, put an elastic band around your cigarette package. You know, this whole idea. So really, you know, if somebody started smoking when they were 16 and now is trying to quit when they're 40, the therapy is basically telling them the exact thing they've known all their lives. It's disgusting, it's not this, but somehow that never got through to them until they had the psilocybin, right? So there's something about you're open to new ideas, which you may not have been in that sense, right? In trauma, what happens is there's cognitive avoidance, like you don't want to think about the trauma, you repress it, you avoid it. So this, again, allows you to sort of entertain those and not have them quite as harsh as they can be, right? So the idea is to really undo some of the stuff. So, you know, we use hypnosis for that, other things as well to reduce people's defenses, but and hopefully get those things. So again, we talked about there's no toxicity per se with psilocybin, but again, there's this transient fear, anxiety, sometimes increased blood pressure, sometimes this idea of paranoia, fear of things going on, and there's the risk of psychosis. So again, when you're doing the study, it's hard to attribute, is this an adverse side effect of a drug or is this the expected side effect? And that becomes sort of tricky when you're trying to do this research. Anxiety, depression, obsessive compulsive disorder, eating disorders, addiction. So there's a whole bunch of areas. People looking at cluster headaches. There's really severe headaches that people will commit suicide with these headaches, and there's studies going on sort of all over the world looking at some of these things. Very similar to, you know, we'll go through these slides very quickly. It's the same as the MDMA. You have preparatory sessions ahead of time, show people the room, give them an idea of what to see. We're actually thinking about maybe creating some VR experiences for people to see what the experience could be like, the sounds, the things. So create virtual reality, help them to be as prepared as possible. The psychedelic drug session, as we talked about, is harsh, can be scary. You're not going to be doing much psychotherapy there. Then you do the integrative sessions afterwards. We've just put a proposal and we're going to do a study in Toronto where we're going to give people psilocybin and then give them cognitive processing therapy for PTSD sort of every day for 6 days. So just the idea of just taking advantage of these things. This is very similar in terms of this same as the MDMA. Same thing again, different drug, different thing, but set and setting is very important. They need to understand and commit to what they're getting into. Their mindset needs to be the thing. And then again, the space has to be very comfortable. They need to know it. They need to understand who their therapists are. All the idea of touch, like if you're going to do something like run into traffic, we're going to stop you, you know, this kind of idea. So all of that is being done sort of, you know, so afterwards. Oh, I should mention the importance of music as well. Music is very interesting where there's playlists on Spotify, all of this stuff. So people are listening to music the whole time as well. So that gets people into the right mood. People are thinking about doing studies. The integrative psychotherapy, again, some of us are looking at, like, you know, there's this new therapies, or maybe the good old therapies will work better if people have had this. So that's kind of where the research is right now. And really, you know, when people, I've spoken to people that have taken it, and months and months later, they're gaining new insights into themselves, into their childhood. So the idea of this being part of psychotherapy, not separate from psychotherapy, I think it's really important to think about. Last couple of slides. I mean, we need to do more research, right? I mean, you know, clinical research, if the governments, you know, and I don't see Health Canada or the FDA as being the bad guys in the situation, but if they're going to approve these medicines and help patients get better in these very difficult to treat conditions, we need to do good clinical research. We need to do proper research, ethical research, and get things going. The research was interrupted by the global war on drugs, but I think that's mostly in our past. In the US, for example, that's why picking PTSD is important, because it's veterans, because Democrats and Republicans all love their veterans. So they're really pushing the Veterans Affairs to sort of do that in the States. We need to understand a little bit more about how these medicines work and what they do and what the process is. And sometimes those are called dismantling studies, sort of separate the acute effect from the long-term effect. And that's why there's so much, interest in the brain imaging and the biomarkers, the inflammatory markers. So those are the kind of studies that a lot of us are interested. Going beyond just PTSD, which was MAPS's thing. And like I said, I'm really, really interested in autism and in schizophrenia and these different kind of conditions where people have difficult, like sometimes with some of these illnesses, you don't have empathy towards yourself. And then you have difficulty sort of understanding relationships with others. And we're just kind of thinking that this may be an interesting thing. Psilocybin is really being looked at in many different areas. Then the idea is, do we look beyond the adult population? This is what happens with knowledge translation. You've done a study in these perfect patients in the real world. What if somebody's 17? Will they benefit from it and things like that? There needs to be sort of not quite lobbying, but education. And I think this is where, when I speak in other countries, like I said, we're not talking about people, they're worried about drug diversion. We're saying the patient never gets it. Like it's one dose that's given and that's it. So it's not like somebody's running around with pills of MDMA kind of things. And I think there's a potential, to really shed light on the mechanisms of mental illness. And I think this is what it is. And I think that for those of us that are in this field, there is an ethical sort of a dilemma in the sense that there's a lot of people that are so-called treatment resistance that aren't responding, and we have a potential treatment available for them. So there is this kind of rush to kind of get this work done and sort of try to help people that are suffering. And I think I'll stop there and open things up for discussion if anybody has any questions. Thanks very much for your attention.
I have plenty of questions, but anyone has questions? I will repeat them so that I'll just stop the sharing, sorry, so that we can see the chat room. Here we go. Okay. It looks like this. Oh, sorry. Slides. No. Yeah, someone was laughing about the psilocybin conducted in barns.
Yes.
Was that scientific? No.
It wasn't science. It was underground. It was underground at that time.
Okay. Okay. Thoughts on psychedelics for brain injury?
Yeah. Well, we're actually looking at that. We are there's studies going on looking at ketamine, which again we're talking about lumping these medications together by Queen's Gang, and we're lumping these medicines together. But looking at psilocybin, looking at the ketamine, looking at some of these substances in mild traumatic brain injury, what we call sort of the concussion, is definitely something to look at, because there is this idea of neurogenesis. Like when I went to medical school, and we learned that if nerves get damaged, they're damaged forever. But the idea that different parts of the brain can regrow, readapt is very exciting. And so we are going to look at, we're looking at, I think there's a study with psilocybin and what's his name, DJ Cook, and his group is involved. And there's a Calgary group that's looking at psilocybin for brain injury. We're doing a study in Toronto looking at ketamine, and really with the new imaging, we can actually show the changes that occur. So we're quite excited because, again, there aren't too many effective treatments for the concussion. So I think that's going to be positive.
I'm surprised that we can still do clinical trials. I thought that was over since the FDA said no.
Not at all. Not at all. I mean, it's funny. Health Canada started to pay much more attention a few years ago after the boundary violations in BC and things, right? So they audit you like crazy. They keep asking questions, which I think is okay. But yeah, it's not. So the FDA has basically said, go back and do some more research. They haven't said that there's no way in the world these drugs are going to work. So it is. The interest has been maintained. So yeah. Microdosing? Yeah. So there's a slide that I skipped through. I said like microdosing is for another day, because the interesting thing about the microdosing is there's even less evidence for it, right? So lots of people absolutely believe in it. There's another question there if you can take a peek at it. There's a when I was in the Netherlands a few years ago, there's a guy that actually makes microdosing like commercially available. And I went and visited his plant. He's got actual little tiny mushrooms, and they come almost in a like, you know how you get the blister pack for gum? He actually gave me a few, but I was not going to import them into Canada. But so people believe in it. People, you know, I have patients that sort of do it. They believe in it. There really isn't the evidence for it, but that's not to say there may not be at some point. So I think that most of the people are researching the full dose, and whatever that means, 25 milligrams for psilocybin, 125 or so for that. How does the frequency of experiencing during these experiences correlate with treatment? Yeah, I mean, the question, excellent question, you know, the mystical experience, and, you know, how does that correlate with the findings? Again, that's a piece of research that we haven't done, because we sit and we say, like, does somebody need to have that full-blown experience? Or can their mind change? In Europe, people have been doing, like, we sort of look at 25, 30 milligrams as the, you know, most people are going to have the full psychedelic experience, and that's kind of the marker of things. But we're not sure whether somebody absolutely has that to be able to treat their depression, for example. And so in Europe, people are giving people 10 milligrams and actually doing psychotherapy with a smaller dose. We're also a bit of a slave to the duration. Like, does it need to be this many hours? Like right now, that's just the accident of the half-life of the drug. But imagine if we had an anesthesia that only lasted 8 hours. So you're going for a very small procedure, like having your wisdom teeth out, but you're still under for 8 hours. So the idea is, one, do we need to have the full experience? We're not sure. So that's kind of what's been done so far in these studies. And the second is, if we came up with drugs with shorter half-lives that sort of more fit the traditional psychotherapy, would an hour of the psychedelic and an hour, so 2 hours in total, be as effective as 8 hours? Because again, a lot of us are worried about the scale. Like, you know, I mean, we've got so much suffering going on in the world. I mean, this 30-hour psychotherapies aren't going to, you know, fit for everybody. Moral injury. Yeah, I mean, I think for moral injury, like, the question is about using psychedelics for moral injury. So for people that aren't familiar, moral injury is sort of the persistent guilt, shame, anger that occurs after participating in or witnessing sort of that something that, you know, transgression of sort of, you know, highly believe your values and things that you believe in. So again, the military, it's, you know, war, killing, things like that. So yeah, I think MDMA, psilocybin, I think they would both be effective potentially in looking at moral injury. And I've actually asked for more of the studies that are being done for people to pay attention to that for a couple of reasons. We talked about how the idea of new ideas, the idea of being able to entertain new ideas, because when you speak to, you know, some of the men and the women that are suffering from moral injury, there's no doubt about what they did was wrong. I mean, you can logically say, given the situation, given the fog of war, you know, like, things happened. I mean, they're not open to pursuing that. So I think with these medications, the idea of introducing new ideas, new you know, commitments, acceptance and commitment, different kinds of therapies, I think definitely this would be an interest in moral injury.
Speaking of acceptance, would there be a difference in gender? Like because you were talking about the serotonin, and
yeah.
So is there a difference in how a woman and a man would react to the?
We haven't. So that's another area for further research, and there is a group that's going to look at sort of whether or not, like the MDMA PTSD trials that have done in the States have been overwhelmingly male for the adult PTSD. And the women tend to have different traumas, right? There's more interpersonal trauma, more sexual trauma, more childhood trauma. So there probably will be a difference, whether that difference is biological or tied to the trauma. So it's going to take some time to look at this. Right now, the dosing is pretty much the same, which again may be an issue, like, because they used to, for psilocybin, they used to give a certain amount by weight. and then they realize that doesn't really matter, like that the usual doses are that. So then there needs to be more sort of emphasis on the gender and looking at gender. How to regulate patients providing. Yeah, I mean, the regulation, no, I think it's extremely important. I was invited to Alberta, and in Alberta, they got a bit of ahead of the curve, and they've sort of actually legislated how the psychedelic assisted psychotherapy clinics will work and who's responsible and things. So I think there is it's a difficult area in the sense that it needs to be to some extent controlled by government in terms of licensing, but then it's our professional colleges that talk about how we conduct ourselves in terms of therapy and things. And so it is a little bit controversial in terms of how these are going to roll out, but it's going to be challenging. And I think that's part of the hesitation that people are having, because once you start leaving the academia and you start going into sort of, strip malls, then you start to risk some of those things. So, but it's going to be a combination of government regulation and our professional associations. Ongoing dissociative disorders. I actually don't know if there is research. I bet you there is somebody looking at sort of cases with dissociation, but I'm not positive about DID. Great. Thank you very much, everybody, for your interest. It was a lot of fun. Okay, thanks.
This is fascinating.
Right.
Thank you.